Hello, everybody, and welcome to this new webinar, this new PCR webinar dedicated to tibial osteotomy. Today, I would have been in Paris with my colleague, but the bomb barrier at the Toulouse airport today changed my agenda. So anyway, first of all, what's new with PCO? So save the date, my friend. Next Congress could be 5th, 6th, and 7th June 2024 in Toulouse. It will be more and more practical. It will be about workshop, hands-on, live clinics with real patients, return to play with real patients, robotic and efficiency. So please stay tuned, the www.practicalcourseorthopedics.com. Today, the topic is to focus about open wedge tibial osteotomy, how to deal with the gap. The gap you just created at the end of the surgery. Everything is done, the plate is there, and you don't know what to do with the gap. So today we will try to solve that problem and to give you practical answers to that problem. First of all, I would like to thank BIOBank for the support for this webinar and for the support for the PCO initiative since the beginning. Once again, thank you very much. And also, I would like to thank you for providing this kind of device, this allograft custom-made device that fit perfectly the gap. And this is my solution, my first-line solution in case of tibial osteotomy. And you can see that with this device, you can have a full feeling, a perfect feeling of the gap. And this is the hematite post-op X-rays. It looks like a normal bone. It's perfect, and I'm very happy with that. So the program to try to solve this problem and to try to understand the gap filling. Kristian Kley from Germany, grafting or not grafting. Matthieu Ollivier from Marseille, the quest for the perfect wedge. Claes from Belgium, bone fillers, the good, the not bad, and the ugly. At the end, we will have several minutes for discussion. So please, Kristian, start. And once again, thank you, my friends, to be with me today for this webinar.
Yeah, thank you so much, Etienne. And obviously, it's a pity that you cannot be with us today. But anyhow, we will do this probably in Toulouse later the year. So talking about medial open wedge high tibial osteotomy, and you raised that already. The question here is the good old Shakespearean question of to fill or not to fill the gap. And this is quite a controversial topic and often asked. So the question whether to put some bone into an osteotomy gap or not. Coming to disclosures for this particular topic, I don't have none. And this is once again open wedge osteotomy, but you could equally argue, well, why should we run into this dilemma of filling the gap if we could close the gap equally? And looking into statistics here, we know that it doesn't really make a difference when it comes to healing, whether you have an open wedge or a closed wedge osteotomy. And knowing this, we know about the advantages that open wedge osteotomies deliver. So let's take this for granted and let's just hypothesize we do open wedge osteotomies, and obviously here we want to fill a gap. If we don't do it, nature has to do it. And we all know about the healing process and that it's a biological process of remodeling with lots of formation in terms of cellular answers that we don't really fully understand. Nonetheless, surgeons obviously try to fill a gap that they leave. And now the question is whether this filling leads to a scaffold that either delivers mechanical strength or serves as a scaffold to actually promote healing. So filling a gap to see patients walking directly after the surgery is obviously paramount, and everybody wants to have that. Obviously, we know that healing hasn't occurred by then. And filling a gap is always an issue. And despite of technical advancements that we have seen, we know that sometimes the sequel or the bone that is created is just not perfect and sometimes weaker or worse than what we've had before. So why change then the topic anyhow? I mean, we know this Alex Staubli series of more than 500 personal cases treated here with a Tomofix under compression, up to 25 millimeters of opening without any problems of bone healing. Well, if we want to change a working platform, then we have some considerations for that. Why shall we do this? So are there potential benefits from our change? Are there potential downsides? And if there is benefits, what are the improved clinical outcomes, or are they due to the gap filling itself, or maybe something else? So the hypothesis for those benefits is actually we want to see faster healing or a lower non-union rate, or potentially other benefits that we may come across in a bit of other lectures or my lecture to follow. So looking at this study, we see that there seems to be an issue with the gap height itself. So they've looked into gap heights and made this up of being one of the decisive factors for union or non-union. Equally, we see this here in this systematic review. Once again, gap height has been identified. But equally, in this study, there is the complaint of an overall inconsistency in the literature regards what healing really is, or as what it should be described. Is it a radiological finding based on X-rays or CT? Is it a clinical assessment? So there is plenty of ways to look at healing, and I guess first and foremost, we have to decide on what that really is in order to compare the literature basis. So this study, once again, shows that the gap height or the bridging distance is an issue, and with increased bridging spans, we see interfragmentary movements, and therefore we can hypothesize there is a mechanical issue the bigger the gap. Then we know from other studies that grafts being introduced into an osteotomy gap can increase the stability of the construct, yet not any stability increasing graft that we put in is great. And we see and know from this study from Wolf Strecker and Jörg Harrer, whom I really respect a lot for their work in osteotomy, is that they've stopped in their own series with synthetic void fillers of tricalcium phosphate, because they have seen a higher non-union rate in this. So the role for void fillers, once again here in this systematic review from Matthias Voigt and Michael Hirschmann, they have equally seen significantly higher non-unions in synthetic void fillers. So that kind of proves what we have seen before. Improved union rates with void fillers in specifically higher gaps or larger gaps. Autograft here is the gold standard, and once again, synthetic void fillers should be avoided. So there is this nice study from my good friend Ragbir Kakar and Professor Wilson from London, England, and they've looked into their own series of osteotomies and had the hypothesis that a precisionally bespoke shaped bone wedge would reduce the analgesic requirements for an high tibial osteotomy, the post-operative swelling, the patient-reported outcome measures, PROMs, and reduce the time to union. So the study had two study arms in this cohort, one using bone graft and the other one not. And power calculation was carried out, and obviously the patient-reported measures and other measures such as swelling were included to the study. So the cohorts actually in both arms were quite similar. This is a nice finding from it, I guess, and it shows that the VAS score in the bone wedge group is obviously improved in terms of fewer pain. Sorry for the dollar signs that got changed here on this setting and wasn't there in the original one. Equally, the PROMs, when we look at outcome measures, Oxford knee score better in the wedge group, and the Coos score better in the wedge group. So it seems to be that pain scores and patient-reported outcomes are improved, but equally they have shown that the swelling is reduced. And this may be associated with some kind of a cork in a bottle effect, that it just stops the hematoma and the secretion out of the bone. Obviously, we have to look at downsides as well. There is obviously costs. It just costs more when you put something inside as opposed to doing nothing. It increases your surgical time. When you use an autograft, then you have a donor site morbidity, and therefore potentially the bone bank is an alternative here. It adds somewhat complexity to the procedure, and by knocking in the wedge, you may even change the gap or the wedge height. But overall, we have to say there is no higher complication rate apart from when you use synthetic void fillers. So in conclusion, bony healing obviously is a biological process and not a mechanical task, and it cannot be done in the moment of insertion. It's impossible to get this sorted, but it can increase the stability. It can equally not lead to a significant reduction of the healing time. But once again, as said, adding a graft leads to higher healing rates, and it adds stability. And this probably, the improved mechanical strength and function of the osteotomy, is what we get from auto or allografts when we apply them. This may or may not be associated with healing rates, and obviously this is a topic that has to be further investigated and discussed. It's somewhat, I guess, the use of allo and autografts is somewhat a bit like an THA analogy, where we have normal total hip arthroplasties and minimally invasive arthroplasties. Both work over time, but if you go for a grafting, then you may see better results in a quicker way. So as take home, we cannot recommend, based on the scientific base that we have, that you fill the graft in a normal general use scenario. But in bigger corrections, it may be a good adjunct as mechanical enforcement or reinforcement, and therefore could be recommended there, and equally to work as a scaffold for healing. Thank you so much.
Thank you, Kristian. Thank you very much for this very clear presentation. So, Matthieu, what's the perfect wedge?
That's a good question. I would try to answer partially, I guess, what is the perfect wedge. For me, it's a huge quest that really occupy my days and sometimes nights, because it's something very complex to understand. I think it is the complex talk of today. So Kristian just said that we need to feel. I hope Stephen after me will say that it's mandatory and give us good outcome at the end if we feel. But now the question is how to do that. And to be honest, it's a very tough question. I start with a case. It's a case that was referred to me by a colleague, saying that he'd done this osteotomy, and you see that. I would say that for me, that's a pretty good case at the beginning. We have a tibial varus. He done an opening wedge osteotomy, and the patient suffered like hell since that day 0. And he was referred to me, and I look at my number and I say, okay, like Kristian showed a few seconds ago, it's his drawing, not mine. It was a good indication. He really followed the tracks on what is the normal value. We don't have big joint obliquity at the end, but this guy is still suffering. And this is the bone scan that he sent me, and you can see that there is a massive problem behind the knee, in between the proximal tibia and the fibula potentially, but I think more or less at the posterior aspect of the tibia. And the reason for that is here. I do think that this surgeon didn't take really into account the problem of inserting a bone wedge and creating a massive unintentional slope change. And if you do that, you may have big troubles with ACL injury, for example, or of course having posterior knee pain because all of the forces get behind because you increase the slope. So having this known, you know that you probably need to know better how to create this wedge, this gap, because it's not really a triangle, and if you really want to use triangular shaped wedge, you probably end up with some cases like that with patients with pretty unpredictable outcomes because you you increase completely the slope. So perfect wedges should correct the frontal plane, maintain the sagittal plane, provide fast bone healing, accelerate rehab, and of course become bone at the end. This is the global scenario of the day. And in HTOs, perfect wedge implies that you do first a perfect sewing plane, because if you have the same wedge for every patient, you also need to have the perfect cut to put the wedge in. And this cut influences a lot the outcome you will have in both coronal and sagittal plane. Second, you need to have a hinge, which is your box opener, where you open your osteotomy gap at the perfect position to avoid any unintentional issues, both in frontal coronal plane and at the same time having hinge fractures. So this wedge have been this cutting line is very easy to define. For tibia, you need to do a 110-degree cut compared to the lateral cortex of the tibia. It's Mignacci and Jacob work from the 90s, and in fact, this 110 is not coming from nowhere. It's the perfect cutting plane. To have enough space above to put 3 or 4 screws to stabilize your osteotomy, and having a cut which is metaphysal with a good healing rate. So your entrance point should create this 110-degree cut. The last point you need to cut is, of course, what we call the hinge, and this hinge should be slightly over the fibula head to avoid leaving a posterior entrapment in between the tibia and the fibula that will avoid the opening of the posterior aspect of the tibia, because the posterior tip fib, the proximal tip fib, stays intact and, of course, make impossible to open the posterior aspect of the tibia. So this, you know what to start, you know what to do, how you do your cut, you know to do the cut pretty high compared to what was described. The last third of the fibula is the rule, which will probably create some mistake on that. Then what should be the angle with the tibial plateau? You should have a cut which is exactly parallel to the tibial plateau to avoid unintentional slope changes. And this is very tough because when you do your osteotomy, usually you only refer to X-rays which are taken in the frontal view. So you only see the AP view of the tibia, and you need to have option to understand how to cut completely parallel to the slope, which is a sagittal view. To do that, we published this in AGSM. You can do that very easily. You need first to understand that you need to see the slope as a very thin line, as you see on the X-ray here, described here. And when you have this actual situation, you need to shoot 2 parallel key wires. So you only see 1 and not 2. If they are superimposed in the X-ray, that means that those 2 key wires are parallel to the X-ray, which is also parallel to the slope, and then your cut is exactly parallel to the slope. So this is the second bad point of the cut. Then, and you of course avoid this kind of catastrophe situation where you completely revert the slope unintentionally. Then where to put the hinge? Where is your box opener? So as I said, and this is a Kristian drawing too, slightly above the fibula head and as anterior as you can. So your hinge should be this green star and not the dark red one, which is the tip fib joint that you need to cup above, and you need to stabilize your hinge at this exact, let's say, yellow to green position to be able to open posteriorly your tibia on the distal tibia onto the proximal one, and to avoid the slope changing that you can create without noticing it. And to do that, the best option was to do exactly what Etienne showed you in his first X-ray, having a protective key wire that will avoid the saw blade to propagate through this lateral cortex at the exact point that you want it. So you put your key wire proximal to distal, let's say onto the Gerdy tubercle, in between the Gerdy and the ALL insertion, and you have your the hinge the wire will create the hinge at this exact position, and they will help you to control your slope and the proximal aspect of the tibia onto the distal when you open. Knowing that, and this is the crucial point of the discussion today, you need to insert the wedge as posterior as you can. And the bad point here is that what you have here at the posterior aspect of the tibia is the MCL. Let's say even the posterior oblique ligament. So you have options. You can completely cut it to put your wedge in, or you can protect it. But if you do that, you need to insert your wedge from posterior to anterior, which can be very tricky because it's a zone where there is potentially vascular issues, when potentially you have this MCL that you need to respect or cut if you want to insert it. And if you cut it, potentially you may discuss an issue of instability, which is very, very rare in HTOs. So then you need to put this wedge as posterior as you can, because you see here on these 3D measures, you can completely change the slope by plus or minus 6 degrees, just having the wedge completely anterior or completely posterior. And really without noticing it, because you only see the tibia AP, so you don't have access to this vision, which is a lateral view, to really focus on this slope, unintentional slope correction problems. And if you ask a company, or if you really want to go to 3D planning, this is what we call reverse engineering process. So we have the initial tibia aspect, the postoperative tibia aspect. We merge that into a model, a 3D model. This is what we have. Though this is the perfect wedge. This kind of wedge was created for a company called Nuclip by Jean-Marie Fayard in Lyon, in a clinique Santi. And he had this sword, and if you really look at it, it's not a triangle. It's a quadrangular shape, trapezoidal shape, with various different slope inside of it to create this movement. If you insert it very posteriorly, you will be able to open only at the posterior aspect of the cortex, not creating an anterior opening that once again create abnormality of the slope. So once again, we published that recently, so all the tips and tricks, and you see on the left down image that the wedge should be a small triangle and not a square aspect. Otherwise, you probably create an unintentional slope change. So you have the version of Steven and Peter Verdonk here that I learned from them. So you can create it with patient-specific cutting guide to create your ideal wedge on femoral head, but you need to know the diameter of the wedge of the femoral head to do that. I learned from Steven directly into his how to do that freehand, which is tough, of course, but in his hand is, of course, perfect all the time. And my version is to create that from BIOBank wedges themselves. So I use those wedges and I resculpt them. And you see that compared to Jean-Marie's sword, which you have on the left, this is what we have with the BIOBank wedge, let's imagine. And I need to create all those slopes in my single wedge. And this is my first one, this is my second one, and this is the final aspect. So I do 2 cuts to make it slightly more trapezoidal. It's possible to do that with a completely triangular wedge at the beginning. You just need to know that you need to recut it. This is the aspect of my wedge in this tibial osteotomy with complete protection of the POL, and you see that I have a complete different triangle, AP to lateral, and this is what you need to have. And this is the 6 months X-ray, and you see we don't see, we have this integration. One of the last things that was discussed by Kristian, do not believe industrial promises. That's completely false. So you have here the 4-year, 3-year, 2-year, and 4 months post-op X-ray. And you see that only one thing becomes bone, it's bone. All the rest of it is not working. Knowing that, we have an ongoing project with BIOBank, so I'm very happy to say that today because they are sponsoring this webinar. So we have analysis with 3D micro CTs. We have analysis with compression testing, and I need to say that the wedge that BIOBank can provide you is pretty insane because they are very strong. For me, it's everything. You can really smash it into your void without destroying them, which is not comparable to anything I ever tried. I don't have any conflict of interest with BIOBank. I don't take any money out of this thing. So, but believe me, it's for me the best thing I can have because it's already disposable in small boxes. I just have to do 2 cuts to reshape it, and it's done. And you believe me or not, this is the 2 same bones with 3D micro CT. And on the left side is fresh, on the right side is after BIOBank treatment, and we found no difference in terms of compression stress or CT trabecular shaped on this element. Thank you for your attention.
Thank you, Matthieu. Then now, Steven, what about the bone fillers? What do you have to say about that aspect? Thank you once again.
Thank you, Etienne. So bone fillers in HTO. Thanks for giving me the title on the good, the not bad, and the ugly. Because all of a sudden I had, of course, to think straight away at this beautiful movie directed by Sergio Leone. And if we transpose this beautiful movie to the setting today, of course, Etienne is the director from a distance today. And I think our good friend Matthieu can be the ugly, and for sure Kristian is the bad as always. And that just leaves me by deduction as being the good, I think. Nevertheless, should the gap be filled in HTO? If you have a question surrounding HTO, my advice would be to check the consensus project statement we did with ESCA just last year, which is freely available online. And there is a question on gap filling in HTO. It goes like, should the gap be filled in HTO? And the answer is, the filling of the gap is not required for routine use in HTO surgery. So this is the statement from the consensus group. We specified a little bit in detail about autograft, saying that they can increase the rate of bone union Allograft options are good, but are probably not universally available. And synthetic void fillers may have an increased risk of non-union. So this is all from the consensus statement. By reading this, maybe the question is already answered. However, the ultimate bone filler ideally has three properties. It's osteoconductive, which means that the scaffold you implant allows the ingrowth of host bone. Ideally, it's also osteoinductive, which means that there is growth factors in the graft which differentiate the host stem cells to form chondroblasts and osteoblasts, and then finally bone. And the graft might also be osteogenic. This means that the graft itself produces new bone. Now, if you look at this table, you see all these three properties above, and you see the three types of grafts, the autograft, the allograft, and the synthetic grafts. You will see that going down, they all perform a little bit worse, and that the autograft has plus signs on all three properties, while synthetics only seems to act as osteoconductive. So you might think about this as being the good, the bad, and the ugly. However, this is still to be answered. Because autograft bone fillers are a good idea and typically taken from the iliac bone, at the iliac crest in the patient's pelvis. But a lot of publications show that there is no effect on final union. This means that the osteotomy heals anyhow, but it seems to shorten the healing time, especially in larger corrections. So 10 to 12 millimeter might really benefit from these autografts in literature, because it will take very long otherwise to close that gap by just forming your own bone. However, there is a big issue with pain and comorbidity at the harvest site, because it hurts, and that's not what we intend. Allograft bone fillers then, there's two sorts of, bone chips versus structural void-filling allografts, especially derived from either a femoral head or an allograft iliac crest. And literature says that actually these allografts, although they lack the osteogenic potential from autografts, they seem to heal as good as autografts. And this study has shown that. However, synthetic bone fillers like calcium phosphates, hydroxyapatite, bioactive glass don't go there. It's been shown that they have a higher risk of infection, higher risk of non-union, and it has stated that the use of these synthetic bone grafts really cannot be recommended. In the US, where they don't have allografts, they say go autologous or go home. So in order not to use these synthetics, that's quite clear. So again, the philosophical question, to fill or not to fill, the answer is bone grafts are certainly not necessary for attaining bone union, especially in gaps smaller than 10 to 12 millimeters. You can see on this X-ray, it heals, even without bone fillers. So what's my point? Indeed, it heals, but the fact is, it hurts. So if you don't use a bone graft, they will heal, but they have pain. And this is the most important reason. We try to get rid of these phases. This is a typical patient when you explain he needs an osteotomy, and they're like, whoa, I'm not gonna have it because it will hurt like hell. It takes ages to heal. I think that is not necessarily the case if you use a technique like this. This is a femoral head allograft we use from the bone bank in Belgium. And what we do during surgery is we create the osteotomy gap and we mimic exactly the positive of this void to a triangular shaped cortico-cancellous graft. It has both cortical and cancellous bone. We hold open the osteotomy gap with this instrument we designed. It's called the gap locker. And we hammer this graft in so that it sits nicely. You have control of the slope, you have control of the gap opening, and actually, even without a plate, the surgery is almost done. It gives big improvements because we published this in KSSTA just a couple of years ago, and what we've shown is that in our series of 110 prospective cases, these patients indeed had very low pain levels if you use this kind of technique. Because what we found is that for the NRS pain score, we saw already the first 4 weeks after surgery an important reduction of the preoperative pain level just that quickly. And then the pain levels drop further on, but the most important drop in pain is in the first 4 weeks after surgery, which is totally the opposite of what people think about as this procedure, especially when you do not fill the gap. Then recovery, they do recover quick. We saw that after 4 weeks, half of them are already walking with 0 or 1 crutches or cane. And again, we see this improvement very soon in the first 4 weeks after surgery. And this is what you can see then in the ward, in the department the day after surgery, people having had an osteotomy just the day before, and they can walk without any nerve block or a specific kind of medication. It's not only early results, it's sustainable. As you know, osteotomy is a very sustainable procedure. That is what we found in this series as well. So they improve very quickly, but the good results are sustained over time. So fill the gap, of course, because this allograft femoral head impaction, which is structural, it's cortical-cancellous bone. If you can fill the gap completely, this will decrease the bleeding from this osteotomy gap and thus leading to less pain and swelling of the leg. It also provides immediate stability, as Kristian has just showed. And it means that when you walk, you start bearing weight on bone and not only on an open void and a couple of screws. So this also improves the pain levels. And of course, autologous bone to allo bone healing is faster, takes less time than a large void to be bridged by your own bone. So filling the gap, yes, we have indeed worked, especially with Wouter van Genechte in his PhD, on a PSI instrument in order to prep this femoral head graft in a 3D printed instrument, patient-specific, and this works as well. This means that filling the gap with this early pain reduction, with this fast recovery, also paves the road for bilateral simultaneous osteotomies. And this is what we also do routinely for people who have both varus medial arthritis in both knees, and we have been publishing on this as well. And so don't forget, osteotomy is a very powerful weapon for treating our medial OA knee patients. It's also possible to heal the gap without filling. Be sure it will heal, but it will hurt. And if you want to get rid of this early postoperative pain, this structural allograft impaction is really a game changer because it affects this early post-op period with regard to pain and function. Thank you.
Thank you, Stephen. Thank you, guys. So don't hesitate if you have a question on the app. I will tell the question to the expert with us today. So I will start with the question. I think we all have understood the sequence you do the surgery, Stephen. Is it the same sequence for you, Matthieu and Kristian? Do you start by filling the gap and then after you put synthesis, or you start by putting the synthesis and then after you fill the gap? And is there any importance from your side? Kristian first.
Yeah, so I have the privilege actually to have an overview on different patient cohorts, as I do work in London and in Hanover, Germany. And in Germany, we have the problem that we don't have wide access to allografts. So there, I just don't fill the gap. In the UK, I do fill the gap, and I first fill the gap, and then I do the osteosynthesis. And what we do there is a bit what Stephen has alluded to. So we do these bespoke wedges. So actually, we plan our osteotomy, then we measure the gap, cut the gap according to the requirements of our osteotomy. As Stephen has said, we form a positive of our osteotomy gap, and then compact it into our gap side. So that is probably everywhere the same process. What we have there is we have hinge wires that protect our hinge for the moment of impaction.
Yeah, I'm exactly doing the same. I'm exactly doing the same. So the procedure, the only thing that we really need to be taking into account is the MCL, I will say. If you protect the MCL, it's always complex to really put the wedge as exact good position. So this is the tricky part, but yes, so we usually maintain the opening posteriorly with a small instrument, for example, just a forceps, and then we put the wedge in to create the opening and to finally maximize the opening to the height that was planned. So this is also a good thing. We create the wedge to be the correction. So you need to take that into account. I know that Steven is measuring this correction intraoperatively based on Ernigout tables, for example. I'm doing that based on preoperative calibered X-ray, long-axis X-ray. So the gap is the wedge is the correction. So this is why you need to be perfect and perfectly positioned at the same time. So you need to have your perfect cut, your perfect wedge, prepare on the table. And in fact, it's insane how much time you earn doing that, because the surgery becomes so easy. You just stabilize the fracture, which is already stabilized with the plate, so you can just shoot the plate without thinking too much about should I put the plate now, what screws, what the length of the screw. So you can do really straightforward plating because the fracture is stabilized already.
Yeah, I think
there is one question.
I think just
go
one
ahead,
comment, Etienne. I think it's really important to do the gap filling first and then put the plate, because this only enables you to have as much as the gap to be stuffed. So you want to have the osteotomy void completely stuffed, because then you decrease bleeding and secretion from the bone. That gives less swelling and pain. And this is the reason why we developed that instrument, the gap blocker, in order to have it completely open. Just in front of you, it's totally open, and you can put the graft in. So this is exactly the same as Matthieu said. And actually the plate, when it's completely filled with corticocancellous bone, just acts to give rotational stability during osteotomy. I even think in the past they could have put a plaster without a plate, but just to have the rotation under control, the plate is needed.
The question is about the method for the osteosynthesis. Do you need a plate? If you do with your technique, is staple enough? What's your point about that?
Chris, take it maybe.
Yeah, I did a couple of slope changes where I impacted bone and actually left it without stabilization implant. I really do not recommend this in general use, and I would definitely say it needs an implant. So this adjunct is not meant to be specific and stable enough to hold an osteotomy site. If we want to promote this, then we have to actually compare it in a biomechanical study to the plate results that we have from angle-stable plate fixators. And obviously, we know that void fillers enhance the mechanical stability of the construct, but they cannot replace a plate.
I totally agree on that. I would say that it's tempting to just put two staples to stabilize the graft from coming out and everything will be okay. I'm pretty sure that you will have massive hinge fractures on the other side because of, let's say, quite of a spring effect. So they compress the lateral side and they open on the medial one, and you will have probably a very high rate of non-union if you don't put something very stable to stabilize the rotational effect and this spring effect that will probably destroy the lateral cortex at the first or second week if they work on something which is pretty unstable. So for me, that's not something which is ready. We can also even discuss maybe something else, which would be to put compression plate once the wedge is inside. To have a very strong effect on compression of the graft and to be able to have something very rigid. But in the same manner, I guess we'll have issue on the lateral cortex because we compress something medially that can open laterally. So keep the same old plates on the wedge is just here to help, but the plate is needed, I guess.
Yeah, also because if you just, of course, the healing goes faster, but it can happen that the bone graft doesn't get incorporated as you want it, and then if you're sitting without a plate, then you're in big trouble. Of course, you lose correction. So I would also advise to use the plate.
You all said that the bone grafting has an important impact on the pain after. Particularly, Steven, you explained that clearly. Kristian, you work in one place with bone fillers and in another one without bone fillers. Do you change your rehab protocol because of that?
Well, I've in both worlds where I work, I do have the same protocol, which actually enables patients to weight bear rapidly after the surgery, if pain tolerated. And the problem, obviously, and this is what Stephen has alluded to, it is painful if you don't feel it. Bone healing occurs basically on pressure onto the bony surfaces. So therefore, it may be a good idea to have more bony surfaces to compress and actually fill. And we see this in the UK, that the patients really have way fewer hematoma, way fewer bleeding issues, and probably therefore reduced swelling and reduced pain levels and higher mechanical strength of the construct. So I would love to have the opportunity to actually offer this at a broader scale to the German patients for high tibial osteotomies. Luckily, I do more distal femoral osteotomies meanwhile than HTOs, and I can close all of them. So probably it's not needed there.
That's a good point.
Stephen, Matthieu, what's your protocol for the post-op? Stephen, I think it's full weight bearing allowed immediately.
Yes, we have them on full weight bearing as tolerated. So we don't push them. If we tell them if it hurts and it really hurts, then don't go there. But if it feels quite comfortable, then they can go for full weight bearing.
What is your statistics for roughly? I don't know if you know data, but how many of your patients after a high tibial osteotomy can really walk at the day of surgery or day after surgery, short term?
We don't test it routinely, but we know that 25% walk without crutches after 4 weeks. So 1 out of 4 comes in walking when they come for the first outpatient clinic.
I would say that for me, coming from a world where we use synthetic grafts with my mentor, Sébastien Parat, some years ago, to the world of only allograft, it's a massive game changer, specifically on your 1 month post-op clinic. I mean, I have the feeling that this patient is just an easy ACL patient. He's coming in without crutches, without any problems, and say, you know, it was very easy for me. I returned back to work finally at 2 weeks. So it really happened in high tibial osteotomy. I will not force that on DFOs, which are a little bit more complex to handle. Specifically, they can break secondary, so we need to slow down the weight bearing. But on those HTOs, when you really do a very complete bone filling with allograft, the results are really amazing. Those guys are really doing very well in 1-2 weeks. And as Stephen said, I have like 1 on 3 that will come in my clinic at 1 month, just working on that, saying, I just drive to the hospital today. I just drove.
Matthieu, one technical question about the device you showed us about the way to open, the perfect way to do the device created by Jean-Marie Fayard. Is it strong enough to be used alone to open the wedge, or do you prepare the opening with other tools before?
So that's a very, very good question, Etienne. I feel that you already tried. So no, it's not strong enough to open. So you need to do complete cut. The problem is usually in osteotomy, people force the opening. This is something wrong. You don't need chisels. You don't need any wedge, metallic wedge to open. It's supposed to open by itself. It's supposed to be soft enough. If you cut completely the posterior cortex until the hinge, which is anterior, you can just use the key wire you put to drive your saw blade to open. You don't need to force in valgus. You don't have to need any compression in valgus to open the gap. So then if you're in this scenario, usually I just use the forceps. It's a technique that Kristian showed me. I put it into the gap anteriorly just to maintain the opening. Then I take the Jean-Marie Fayard sword and I put it onto the bone posterior to the MCL. And this just opening the osteotomy side very easily, very softly. If you hear a crack, you do something wrong. I remember in the old days, my mentor saying, if it's not cracking, it's not good. If it's cracking, it's a hinge fracture, it's a catastrophe. You know, if I hear a crack, I'm very disappointed usually. Yeah.
Last question, and for you, all of you guys, and you just have to reply with one number. We have a lot of questions about the size of the gap. How much opening do you accept before going for a wedge? Kristian, Matthieu, Steven, one number, each one.
Without doing anything, you mean leaving it alone?
Yeah.
Leaving 0.
Yeah, I would be confident to have large gap openings without anything, because we know from literature it works. And actually, I have to do this in one country where I work, so I cannot comment on a specific number here. We used to say in the past with Lobenhofer 14 millimeters, and then we fill. But we live in a double level world today, so we don't open 14. That was not one figure as an answer.
Yeah, and we always fill, even in the slightest correction, because the funny thing is, if you open only 4 millimeters or 14, it hurts the same for your patient. And if
the bleeding is the same.
The bleeding is the same. The pain of the osteotomy, the fracture you create is the same. Pain is not related to its size of the opening. So the reason why we fill is because of the pain, and so it makes sense to fill every gap.
It's a great answer.
Thank you very much, guys. Thank you very much. It was very, very nice to do this webinar about this very specific topic about gap filling. I would like once again to thank BIOBank, particularly Thierry Scandola, Patrick Jouka, Alexandre Tepas for the support in the beginning. And don't forget to save the date for next PCO Congress, June 5, 6, and 7 in Toulouse, 2024. Thank you very much, everybody, and enjoy the night.
Thank you. See you soon in person.
Yeah.